Hi everyone and good evening. Myself Dr. Bharat Kumar VD. I am the Pharmacology faculty, DBMCI eGurukul. So we will be discussing today the recall questions from NEET PG 2022. The pharmacology questions. Just a minute. Yes, we are ready to go now. Yeah. So let me check your messages. The audio video is fine. Then we can proceed further. Pharmacology questions. Just a minute. Okay, so let us begin the recall questions. And how was pharmacology? I hope a bit easier questions, and most of them are repeated. So let us see what are the questions, and these are all recall based. So in the comment section, if you have anything to change the options, if you find the questions are different, just you can comment on the YouTube message box. So let us start. So the first question, what I'm going to discuss is, which of the following drugs has least side effect on pleura? Now, metformin, bromocriptine, methotrexate, nitrofurantoin. Now remember, bromocriptine and cabergoline, these two are D2 agonist and they are derived from ergot. So the ergot derived, they can cause the fibrosis of pleura, not only pleura, peritoneum. And methotrexate is also a derivative of ergot. So methotrexate was once used for prophylaxis of migraine and it's an ergot derived. So anything derived from ergot, they are known to cause the fibrosis, particularly pleural fibrosis. Bromocriptine and cabergoline, they can also cause what we call it as cardiac valvular fibrosis. That is why when we start the patient on this bromocriptine cabergoline, we need to do the cardiac scanning. The S2D scanning should be done. So now we are left with the two options, whether to choose metformin or nitrofurantoin. Now we have come across metformin a lot of times and never ever we have read that metformin causes the pulmonary or pleural fibrosis. So even if you don't know anything about nitrofurantoin, you can tell that metformin doesn't cause anything with pleura. Will nitrofurantoin cause? Yes, there are certain cases where nitrofurantoin has caused the pleural fibrosis. So the correct answer is metformin. What are other things metformin will cause? Is it will decrease the B12, and the main problem is lactic acidosis and the GAT upset. These are the main issues what we see with metformin. Another one is GAT upset. So here the right answer is metformin. Metformin doesn't have that issue, right? Now let us move on to the next question. What is that question? A patient present with severe headache associated with photophobia, which of the following, and phonophobia, which of the following drug can provide immediate relief to this patient? So a patient present with severe headache associated with photophobia, obviously without any history, we can diagnose it as the migraine headache. So which is used for immediate relief is a question. Propranolol is mainly used for prophylaxis of migraine. Sumatriptan is the drug of choice for acute attack of migraine. So in this patient who has acute attack of migraine, then the right answer will be sumatriptan. That is the best answer. Now please comment if there was any change in the options. Topiramate, flunarizine. So topiramate, the anti-epileptics like GST. What is GST? G for gabapentin, S for sodium valproate, and T for topiramate. These drugs are used for migraine prophylaxis, which are the anti-epileptic. So you remember them as GST. What about flunarizine? Flunarizine is a T-type calcium channel blocker that is also used for migraine prophylaxis. So what is used for acute attack? It's none other than B-sumatriptan. That is the best drug. Moving on to the next one, which is the hormone receptor antagonist, growth hormone receptor antagonist? A direct question. What is mecasermin? Mecasermin is a recombinant insulin-like growth factor 1. Where do I use it? When there is growth hormone receptor mutation, or when there is growth hormone receptor antibodies. If there is antibodies on this, then we use it. Or when there is insulin-like growth factor 1 deficiency, there we use this mecasermin. Then what is pegvisomant? So pegvisomant is a growth hormone receptor antagonist, and this is the right answer. Now you can read the name itself. Soma, that is growth hormone, it's an antagonist for that. So it is used in the treatment of acromegaly. Pegvisomant is used to treat acromegaly. What about octreotide? Octreotide also used for acromegaly, but it is a somatostatin analog. It's not a growth hormone receptor antagonist. What about ubrogepant? Anything ending with gepant, they are CGRP antagonist. And it is used for acute attack of migraine. Acute attack of migraine. Similarly, we have ramogepant, ubrogepant. Another CGRP antagonist is there, that is CGRP blocker, and that is called erenumab. Now remember, erenumab is not for acute attack of migraine. This is for prophylaxis. We give it as once monthly injection. So it is for prophylaxis. So yes, pegvisomant is the right answer. Let us move on to the next question. 14-year-old girl was intoxicated with botulinum toxin. Which of the following tells the mechanism of action? Now what is botulinum toxin? NM receptor and produces muscle contraction. But when there is botulinum toxin will not allow the release of acetylcholine. It decreases acetylcholine release. So what happens in the muscle? There will be muscle, particularly skeletal muscle relaxation. So this botulinum toxin is used locally, not systemically, because if you use systemic, it's one of the deadliest toxins known to the humans. It can cause death. So what we use botulinum toxin is locally for the wrinkles, glabellar lines, cosmetically, and muscle spasm like blepharospasm, achalasia cardia, right, and strabismus, cervical dystonia, where we can use it. So here the answer is B, inhibition of acetylcholine release. Direct stimulation of muscarinic nicotinic receptor doesn't do that. Inhibition of nicotinic receptor, nothing. Increase acetylcholine release. So this increase in acetylcholine release is done by a toxin by black widow spider toxin. Black widow spider toxin, which is not commonly seen in our country. But for black widow spider toxin, we have an anti-venom for that. For the pain, we give opioids. Okay, Satyam, you have skipped this question. It's okay. A boy presented to the emergency with vomiting. Parents gave history of consuming 8 tablets of ferrous sulfate. So in our revision sections also, I told you antidotes should never be skipped in your preparation. So ferrous sulfate means iron. Patient is having acute iron poisoning, and we give an antidote, and that is a chelating agent. So the chelating agent what we use in acute iron poisoning is desferrioxamine. This is the right answer. Desferrioxamine can be given IV or IM. That is the antidote for acute iron poisoning. But there is something called chronic iron poisoning also that occurs in repeated blood transfusion. Then we use oral iron chelator. They are called deferriprone, and one more is deferricirox. These are for the chronic iron overload. Remember, one more important point I want to add up here is iron poisoning. We should not use BAL, British anti-lewisite, or also called as dimercaprone, because the complex which is formed with iron and BAL is itself toxic. And not only that, this BAL should not be used in cadmium poisoning also. So guys, the answer is yes, ferrioxamine. So most of you will confuse with one more, that is called dexrazoxane. So dexrazoxane is an iron chelator which is used to prevent cardiotoxicity. It is also an iron chelator which is used to prevent cardiotoxicity by anthracyclines. Cardiotoxicity by anthracyclines. Anthracyclines means daunorubicin, doxorubicin, idarubicin, valrubicin for that. Okay, yes. Now let us move on to the next question. Patient on digoxin presents with pulse rate of 50, third degree AV block, best step is. Now digoxin, even the usage has come down, but the questions have not come down. Digoxin toxicity was asked in last year PG, NEET PG also, and now also. Now patient has come with the pulse rate of 50 and there is AV block. Remember, digoxin toxicity, the most specific arrhythmia what we see is atrial tachycardia with AV block. With AV block. So if there is suspicion of heart block, that means we are suspecting digoxin toxicity. And normalization of ventricular rate. Why? Because there is AV block, so the ventricular rate will decrease. So there will be no conduction from atria to ventricle. So it's a case of digoxin toxicity. So digoxin toxicity, you know that the antidote for digoxin toxicity is digipine. It is also called as digifab. And this is an orphan drug. But whenever the digoxin toxicity occurs, there is a risk of arrhythmias. So any supraventricular tachycardias, the best drug can be beta blockers. So digoxin-induced SVTs, we use this, or digoxin-induced VT, the drug of choice will be lignocaine. This can be done. Can we use DC cardioversion during digoxin toxicity? No. Never we should do DC cardioversion because there are so many arrhythmias in digoxin toxicity, and cardioversion can worsen that. Digoxin toxicity. Can we use potassium? Now remember, potassium should not be used in acute digoxin toxicity. Because in acute digoxin toxicity, potassium is already high inside the circulation and hyperkalemia can occur. Then when to use potassium? Potassium can be used in digoxin toxicity when there is chronic digoxin toxicity. So you know that potassium and digoxin are enemies. They will not match each other. Right? So let me check your messages, guys. Yeah. So I hope no other confusions with that. MTR tuberculosis, multi-drug resistant tuberculosis, a simple term. MDR TB is nothing but there is a resistance to isoniazid and rifampicin. So the main drug, primary drug H and R resistance, we call it as MDR TB. Extensively drug resistance TB, we call it as when there is resistant to H and R plus one second line injectable, that is the aminoglycosides like apomycin, amikacin, then kanamycin plus one fluoroquinolone. So all these four should be involved, and only we call it as XDR-TB. So it's an easy one. The answer is B, isoniazid and rifampicin. So no controversies in that. A deep vein thrombosis patient was started on an anticoagulant therapy. Next day, the patient present with the features shown in the diagram below. Likely drug implicated for the adverse effect is. Now, if you see this is a case of dermal necrosis. This is what the students are told. And what is the drug which can cause this skin necrosis or dermal necrosis? The drug is called warfarin. Why warfarin will do that? You know that warfarin inhibits vitamin K. So it's a vitamin K antagonist, so that the protein C and S are not activated. You know that protein C and S, they are opposing the clot, and the one which are making the clot are 2, 7, 9, 10. Now, when I give warfarin, there is an imbalance between these because they have different half-lives. So if I arrange them from short to long, 7, then protein C, 9, protein S, then 10, factor 2, like this. So when I use warfarin will not work immediately. It takes 3 days to start working because the shortest half-life is with factor 7, which is around 6 hours. The longest is with factor 2, which is around 60 hours. So they will not disappear quickly. First one to disappear quickly, the active form is 7, then C, then 9 and S. So till now the dominant will be 10 and 2. That means the clot can form. So the clot can form and a patient may end up with the necrosis of the skin necrosis. Now what should I do so that this complication doesn't occur? This is an immediate complication. Within 1 or 2 days it will start. To prevent this, what we do is always when we are starting a patient on DVT, on application is you have to start with heparin or low molecular heparin plus warfarin. So it has to be continued for 5 days to avoid this clot formation, and then the injection low molecular weight heparin can be stopped. So this is what we can do in this case. So what about heparin? Heparin mainly causes bleeding. The antidote is protamine sulfate. It can cause alopecia, right? And heparin-induced thrombocytopenia is a major complication and osteoporosis. Rivaroxaban is a direct NA inhibitor. Dabigatran is a direct thrombin inhibitor. It's an oral drug. Mainly they will concentrate nowadays on these drugs. They are called novel oral anticoagulants, and they will be asking you the antidotes for them. Please concentrate on them. If you're watching this video and you are preparing for the next NEET PG, please consider that they are called NOACs. And they will also ask you to identify the mechanism. So it's a 10A inhibitor. Now let us move on to the next question. Again, an easy one. Drug of choice in paracetamol overdose. It's a direct question, NS assistant. Right? So recently this appeared in INICET. They had asked NABQI is produced by which drug. So that means you are getting a hint to get that paracetamol may be asked. Carnitine is used to treat mainly valproate hyperammonemia. Flumazenil for benzodiazepines, a drug, and beta-carbon toxicity. Fomepizole is mainly for the alcohol, that is methanol and ethylene glycol poisoning. So that's what I told you when we had the revision classes, the last mile, and we covered the last, that is all the antidote list. In the antidote list itself, we got 4 questions from this. Now let us move on to the next one. Acute opioid overdose treatment is naloxone, naltrexone, fomepizole, methanoltrexone. Now acute opioid overdose treatment, obviously we have to give an IV drug, that is called naloxone. Naloxone is the drug of choice. Naltrexone can be used, but it is the second line drug. Only when the patient is from ICU, he can be shifted to the wards, then you can give naltrexone. Otherwise, management is naloxone. Not only naloxone used there, whenever we use opioids during labor, so the baby is born, the baby may have respiratory depression. For that also we use naloxone. Naltrexone, it has so many uses now. Naltrexone can be used in opioid overdose, obesity, it is used along with bupropion. It is also used, naltrexone, to decrease craving in smoking. Smoking and alcohol. Fomepizole, I told you, it is for ethylene glycol and methanol poisoning. And methanoltrexone, it is used to treat opioid-induced constipation. Yes, let's move on. A patient present with hyperkalemia, which of the following drug can decrease serum potassium levels? Now, atropine has nothing to do with this. Lactic acid has nothing to do with. And what we come to the point is glucagon and epinephrine. Now, epinephrine, obviously, it acts on all the receptor alpha 1, alpha 2, beta 1, beta 2, and a weak beta 3 action. So what is the role of beta 2? Is to shift the potassium from outside, that is from the blood vessel, into the cells. it will shift the potassium into the cell. So that can decrease the potassium. It will shift the potassium into the cell. Which cells? Liver and skeletal muscles. That is the epinephrine. Now, what about the management of hyperkalemia? What we use is the beta-2 agonist, that is salbutamol, can be used. Hemodialysis and remove that. What about glucagon? Now, glucagon also can cause hypokalemia, but the better one is always an epinephrine, which has to be chosen. Then where do I use glucagon? Glucagon is used whenever there is hypoglycemia due to insulin. To correct that, we can use it to treat hypoglycemia. And also it is an antidote for beta blocker toxicity. Antidote for beta blocker toxicity. Overdose, that is glucagon. But whenever there is hypoglycemia, we give glucagon, but that is not the only thing we can do. After some time, you have to give glucose, because if there is less hepatic store of glycogen is lesser, glucagon cannot release glucose into the circulation. So that's why we give glucagon. After some time, we will give oral glucose also. This can be done. Now, yeah, whatever initial step Nandakishore, it should be apart from digibind, no other option come to the picture, because AV block, we suspect digoxin toxicity. So it will be digibind or digify. That will be the answer. Now moving on to the next one, TCA toxicity, the tricyclic antidepressant toxicity. Now you know what is TCA, tricyclic antidepressants. What do? They inhibit the uptake of noradrenaline, serotonin. Not only that, they also block histamine receptor, causing sedation. They cause muscarinic blockade. It is like atropine action. So muscarinic blockade can cause dry mouth, blurring of vision, then urine retention, constipation. Not only that, they can increase the heart rate. Now this overdose can lead to long QT syndrome. So patient may go for long QT syndrome, the risk of arrhythmia. Not only that, high dose of tricyclic antidepressants can end up with seizures. So remember, TCAs can end up with two things. The risk of seizures. Why seizures? Because you have increased the noradrenaline levels and you have blocked muscarinic receptor. So there is risk of tachycardia and long QT syndrome. It can also block alpha receptor and cause decrease in BP. That's not a major issue, but remember, TCA poisoning, there are two conditions which is problematic. One is the CNS and one is the arrhythmia, CVS condition. Now, this risk is increased in the cases of acidosis. So, as the acidosis increases, the risk of the seizures and arrhythmia increases. That is why we have to use sodium bicarbonate to combat this acidosis, and that's why the antidote for this is sodium bicarbonate. Can we use physostigmine? Now, physostigmine is not used for this condition. It itself can increase the risk of arrhythmias. Lignocaine, yes, we can use lignocaine if you suspect ventricular tachycardia. Diazepam is used to manage seizures. Lignocaine if you suspect VT. This is the purpose. So the answer will be sodium bicarbonate. Now moving on to the next one. A pregnant female with urinary tract infection took antimicrobials for the same. The baby of this female developed tendon rupture and arthropathy. What is the likely mechanism of action of the antimicrobial consumed by the pregnant female? So pregnant woman, they have given a drug for UTI, and the baby has developed tendinitis and arthropathy. What is a drug which can cause tendinitis and tendon rupture? We have discussed this a lot of times. They are nothing but fluoroquinolones. So fluoroquinolones are never given in pregnancy, but here they have given it, and because they damage the tendons, they damage the cartilage, we are not going to use it. So they have asked what is the mechanism of action. So the mechanism of action is they inhibit DNA gyrase, particularly in gram negative. Gram positive, they will inhibit DNA topoisomerase 4. Folic acid synthase inhibitors are nothing but sulfonamide, dapsone and PAS. Sulfonamide, if I are using in pregnant women, particularly last time, when the baby is born, there is a risk of kernicterus. Mycolic acid synthesis inhibitor is isoniazid. Protein synthesis inhibitors, we have so many. Aminoglycosides, tetracycline, linezolide, chloramphenicol, macrolides, clindamycin, quinprestin, dalfaprestin. Shruti, how many questions from pharma? Totally around 20 questions. So the weightage of pharma is always there. And this time it was simple to answer. There were around 20 questions. That means out of 200 questions, 20 means 10% weightage. It is integrated with the other subject also, but when ultimately the pharma is a treatment, you have to depend on for all the disease conditions. A female with ovarian cancer was on cisplatin therapy. He presented to the hospital with several episodes of vomiting. After giving an antiemetic drug, the patient developed dystonia. The antiemetic drug most likely to be responsible for these features. So this is a repeatedly asked question. There is nothing new in this. Metoclopramide. It was a question which was asked in AIMS exam 3-4 years back. Recently also it was asked. They directly gave the question, metoclopramide was given and patient developed dystonia, then what will be the treatment was asked. So now they have changed it, that's it. So the drug is metoclopramide because it crosses the blood-brain barrier and blocks the D2 and responsible for developing extrapyramidal symptom. The extrapyramidal symptom that occurs is sudden muscle dystonia, or it may be acromegaly crisis, which was recently asked in your INACT also. The drug was risperidone. High dose of risperidone can cause D2, and even haloperidol or typical antipsychotics can cause this. What is the treatment for this? It is injection promethazine, which is available in the casualty, that can be used immediately. If that is not there, you can choose benzoxazole, which is a centrally acting anticoagulation drug. This can be used. Yes, Anish, you are right. Pranay Sinha, you are right. So acromegaly patient surgical removal was not complete. What will be the used? So I had only two options. I got octreotide is the one which we use for acromegaly. So what is the treatment aspect for acromegaly? I don't know whether the two questions were asked from this. One is the growth hormone receptor antagonist. The growth hormone receptor antagonist is called pegvisomant. This was a question which was already asked from the exam point of view. Second is you can use somatostatin analog. They are octreotide. You can also use lanreotide. And one more is pasireotide. Right? So these are the drugs. And one more important ones are the D2 agonist. What are the D2 agonists? They are bromocriptine and cabergoline. Bromocriptine and cabergoline. So these are the drugs what is available for acromegaly. Other options was buserelin, goserelin. Yes, if it is was there, buserelin, goserelin. Remember, buserelin, giserelin, these are anything ending with relin, they are GnRH agonist. So these agonists can be given in two ways, either continuous. If you give continuously, they will decrease estrogen, progesterone, testosterone. If you give them intermittent, they increase estrogen and testosterone. Based on that, we use in the conditions. Yes, yeah, Ashish, thank you for the options. Yes, something were the options. Okay. Okay, so in between I will, there are certain other questions. So tell me, how was Pharma? Yogesh, Pranay, Ashish, Anish, Nagada, tell me, how was it? So quite easy. A patient was started on anti-tubercular treatment. He presented with tingling, numbness, and other features of peripheral neuropathy. What should be the treatment of this patient? So obviously he is on treatment for tuberculosis. The first line drugs what we use is HRZT. So H means isoniazid. Isoniazid, remember, for mainly two important adverse effects, hepatotoxicity and peripheral neuropathy. Suppose if the patient develops peripheral neuropathy, you have to give pyridoxine. The vitamin is B6. So the answer is B6. So that will be the best answer here. B3 is niacin. B1 is thiamine. B12 is the hydroxycobalamin, cyanocobalamin, like this. Niacin is used in the dyslipidemia condition. Mainly is used for, I'll write you, thiamine is used in alcohol condition, that is delirium tremens. You can also use it in Wernicke's psychosis. Niacin is one of the beautiful drug which increases HDL, that causes maximum increase HDL. But why are we not using it? Because of the adverse effect. It can increase the risk of diabetes. It can increase the risk of uric acid, will be increased gout, and pruritus and flushing. B12 is nothing but hydroxycobalamin. Yes. Okay, thank you. Your notes were helpful. Ashish, thank you. Yeah, moderate. It was moderate. Yes. So please remember, stick to your basics. Now, any exam, it's like that. You have to stick to the basics. They will have some basic questions. Even they give high-fi questions. First of all, are we doing correctly the easy questions? Are we doing the right answers for the repeated question? Now, only when we do that, even the tougher question, yes, it will be confusing for others also, but the one which is repeated should not be made a mistake. That's the only thing we can learn from this. Anti-epileptic drug of choice in hyperkalemia. So recently that was asked as a West syndrome. West syndrome, that is infantile spasm. In that, the most common, the EEG abnormality will be hyperkalemia. So for this, the drug of choice is ACTH. That is the one which we use it. Hyperkalemia, it is ACTH. Right, a direct question. Now, I don't know whether this question was there. Patient present with acute episodes of breathlessness and chest x-ray shows pulmonary edema. History reveals that the patient has uncontrolled hypertension and is not taking the medication regularly. Which should be the management of this patient? So, even if I don't know anything, if I read the option intravenous nitroglycerin, salbutamol, oxygen plus nebulized salbutamol, salbutamol has nothing to do with pulmonary edema. So that is ruled out. So what is left out is nitroglycerin, because nitroglycerin can take care of the acute CHF that can occur and pulmonary edema, and it can also take care of the hypertension. So that was the one. So one more option was oxygen and antibiotics. Even that is given. That will not be the answer because there is no risk, no infection history only. Then why are we using that? So oral salbutamol was there in the option. Let me write that also. But even that will not help in any ways in this case. Okay, just a minute, I think. So that will not help us, even oral salbutamol. Lamotrigine was there in the one of the options. Okay. So there was a radiograph for this. A radiograph. So bad wing appearance, pulmonary edema. So that will come to that. Yes, Pranay, you are right. Most effective drug to control tremors, rigidity, and bradykinesis in a patient with Parkinson disease. So how many of you written this? Obviously, haloperidol cannot be used at all because it's a D2 blocker and it will worsen Parkinson disease. Now we are left with selagelin. It's a MAO-B inhibitor, and entacapone is a COMT inhibitor. Selagelin has shown to produce some neuroprotective effect. Now, what is the drug which can control this tremor, rigidity, and bradykinesis? Remember, the best drug till today is levodopa. That is the best one to control these symptoms. And selagelin, entacapone, they are only additive drugs. So till today for Parkinson management, it is levodopa plus carbidopa. That is the one which is best one. If donepezil was given, that is used in Alzheimer's disease, then you can choose selagelin. If they have given that, you can go with selagelin because selagelin has the neuroprotective effect, so I can choose that. So if there was only selagelin, so if levodopa was not there, let us assume that it was not there, then you can choose selagelin will be the best one because that is the only drug we use in Parkinson's disease. Yes. So if it is there, then we can choose that. Okay, thank you for your options here. Yes. So we can choose that. But if in the future, if they ask you what is the best one for Parkinson's disease, it is best one is, even the same question repeats, levodopa. But which is the best one to control tremors? If they ask you only tremors, it is anticholinergic drugs. Tremors are better controlled with anticholinergic drugs like benzexol, benztropine, piperidine, procyclidine. This will be better. So there are so many options I'm getting. So clozapine is there. So obviously clozapine is there. It's a atypical antipsychotic, nothing to do with Parkinson's disease. And then haloperidol, it is not there. Selegiline is be taken. Okay, so then we come to that. Selegiline as the answer for this. Okay. All right. So with that, we'll wind up the session, and these were the pharma questions which were recalled, and I got that from the students, and I hope it was easier. That's why we could finish the session so early. So just tell me any other questions I'm missing, and I will be discussing that. Okay, even Shubham, donepezil is there in the option. That means it's a drug for Alzheimer's disease, so we'll rule out on that. Was there any question on arrhythmia, like monomorphic ventricular tachycardia? If that was there, I think amiodarone will be the best one. Okay, I hope so. Most of the things we have discussed in our classes, and only thing is we should not panic. So I hope your results will come with the flying colors. So relax, guys. You have done your best. I know you had that frustration of postponement. You had prepared very well. So in between, you had these messages of postponement. You had a lot of obstacles in between, but still you kept your focus on. You did well. So please relax now. It's time to relax, because when you finish these type of things, you get a gap. You have to relax. Don't worry about the good ranks, and become beautiful doctors for the society with compassion, right? Yes. See, obviously IV amiodarone will be there. If it is an emergency, obviously we have to monomorphic VT, we will give IV. And then if the patient becomes stable, we shift him to oral. Because I am not getting the correct question. So let us see. If you get a correct question, then even Tamim sir will be discussing that question. I think we'll see that. Thank you all. Take care. We'll meet up soon, and we will meet up with your ranks, very good ranks. I hope you all the very best for the results. Until that, enjoy your days, because we don't get so many days, because you already had so many things for your preparation. You have taken your time for that. Until results, leave apart all these things. Enjoy. Take care.